all? Wow. Yeah.
We were assessing the vertical wheel, like the thing that's like that.
Yeah, in the back.
So I went what do you mean now?
Did she really?
No, I faked one. It was like, are you serious? Because I would be jumping in the air if it did.
Heavy bad.
Hello, everybody. Can you hear me? Are you locked, awake, alert, enthusiastic? Yeah. A few of those. A few of those. They used to sing to us in the morning at church to get back on. We got approximately 45 minutes of sleep. They asked if we were locked, alert, awake, enthusiastic, and the answer was always, yeah. Okay. Wow. Okay, so today we're going to talk about ethics. If you haven't already, I started the academy to make sure you're signed in, okay? So this is typically a student's favorite kind of class of the semester, I know. Some topics are more exciting than others, but for this particular topic, I have lots of stories. And last time I taught this class, I was like, oh, I'm sorry for so many stories. They were like, no, please tell more. So I have several stories to share with you from practice because, unfortunately, we're faced with ethical dilemmas very often in nursing practice. But several of the stories I have to tell you are some of my most interesting ones, so hopefully you enjoy it. Of course, let me know if you have questions along the way. Alright, so let's jump in. So, of course, we've talked about ethics in this class before, right? And so, what is ethics?
It's like right and wrong, basically.
Right and wrong. So, was that again?
It's right and wrong, basically.
Yeah, it's basically doing what is right, okay? And so it's the morals. And oftentimes we're faced with dilemmas. We don't know which way to go. You guys ready for class? I don't want to talk over you. Okay, thanks. Alright. So, there's no right way to do the wrong thing. Okay? So sometimes you're faced with situations where you have to do something wrong in order to do something right, and that's an ethical dilemma. And we'll talk more about that, okay? But just understand that it is doing the right thing, which is required of us in the profession of nursing. So of course I always give you guys objectives in the clicker and worksheet. Alright? Or the keyboard. Or the mouse. That's fantastic. Oh, hey, you want it? Okay. Alright. So of course you have your objectives. You guys can read those independently. So let's begin first with defining ethics. We've already talked about it a little bit, but it formally is defined as the study or examination of morality, which is doing the right thing. Okay? There's a variety of different approaches that we'll take a look at. So your response to an ethical situation is a reflection of core values, beliefs, and the character that make you the person you are, and also the professional that you will be. Okay? So it's like, what is it that you do behind closed doors? Okay? If no one's looking, are you going to take the shortcut, or are you going to go the extra mile and do what's right for your patient? And I would like to hope and pray that you go the extra mile. Okay? So your actions in response to ethically challenging situations that you definitely will face require courage, compassion, and commitment. And I'll share with you a story later on that we'll analyze about how I was a nurse for about 6 months, and I was faced with a huge ethical dilemma. It was very intense. Alright, so this is the scope of ethics from your book. We're mainly going to focus on professional ethics, okay? Because that's what we're talking about how ethics apply to our profession of nursing. So, we know that there's ethical standards by which we are bound that we must abide by as nurses, okay? And that's the ANA Code of Ethics. We talked about this on day 1 of class. I know it's been a minute, but we did talk about the Code of Ethics. And we understand that we're held to a higher standard because we are privileged in our role in society. Because many times we take care of patients when they're in their most vulnerable state, okay? So, of course, this Code of Ethics is a code of conduct by which we carry ourselves, okay? Alright, so we're going to real quickly run through these, and then, like I said, we have all kinds of stories. Alright, so there's several of these that we'll talk about. Provision 1 is to practice with compassion and respect. Okay, so this is just a reminder of what the Code of Ethics actually is and what we are bound by as nurses when we take that oath. Okay? Provision 2 is commitment to the client and the family. The third one is to promote and advocate to protect our clients. What's being an advocate? What does that mean? Speaking up for a patient when they're not able. Very good. All right. Number 4 is being responsible and accountable for our practice. What does that mean? In your own words. Owning up to it if you do something wrong. And that kind of piggybacks on, I'm sure Miss Beck probably talked about just culture with safety. What is just culture? Do you guys know? What is it?
Isn't it?
Not everybody. What's just culture?
It's not being automatically penalized when there's an error.
Yes, not being automatically penalized when there's an error. So if something goes wrong, a just culture is that you're in an atmosphere where instead of placing blame and being mistreated for speaking up, it should be a culture that's fostered where you feel safe speaking up when an error is made, whether it's your own or someone else's, and that we're not trying to point fingers, we're trying to improve the care moving forward and prevent that from happening again, okay, rather than beating somebody up. So it's a safe place to speak up when there's an error. Very good. So if we do something, then we have to be accountable for it, whether good or bad, and of course be responsible for our actions. Okay? Number 5 is the same duty to self as to others. Okay, so all these things apply to us ourselves as well. If you don't take care of yourself first, you can't take care of others next. Okay? Alright, number 6. Establish, maintain, and improve healthcare environments. Alright? And that kind of goes back to the just culture. You make an improvement based on speaking up if there's an error made, so we can analyze it and prevent it from happening again. Number 7 is participate in advancement of the profession. How can you do that?
Go back to school.
Go back to school. Okay. Yes, very good. What else? Certifications. Very good. What's the difference between a certification and a license? What's the difference?
Certification is like a short time period, it's less education.
Okay. Okay, yes. So certification, she says, a short time period, there's less education involved, however, it is educational. Whenever you get certified in something, typically there's a time period on that, where you have to renew if you want to continue it. But it doesn't necessarily give you the right to practice in a certain capacity, whereas a license does. When you graduate, you must take the NCLEX. If you pass successfully, and you will, then you will become a registered nurse, and you'll be licensed to practice as a registered nurse. Versus if you're a registered nurse, and then you're certified in advanced cardiac life support. Okay? You're not just an ACLS person, you are just certified in stating that you're competent to be able to perform the duties within that certification. Okay? But you're not necessarily a specific role. That's kind of different. But yes, so certifications is another way to advance your profession. How else?
Noticing things that can be improved within your practice.
Noticing things that can be improved in our practice. Very good. And how do we go about changing it?
Talking about it with people who can actually do something.
Okay, talking about it with someone who can do something about it. So a key term for that could be a stakeholder, someone who has an interest in improvement and has the means by which to improve whatever it is you're looking to make better. All right, what else?
Staff meetings.
Staff meetings, very good. Okay. What else? Research. That's kind of what I'm looking for. Very good. All of them are important, yes, but also research. So what is research? How does that advance our profession? Yes. So through research, we discover the best practices. And best practices, through evidence, guide us in our practices, okay? So whatever we're implementing in our care should be evidence-based, and that is another way to improve the profession. So even if you're not the one conducting a study, if someone approaches you, hey, would you be willing to fill out this survey, or hey, would you be willing to be a research participant, unless you just have a real aversion, it would be great to join in and help, because that's the way that you're contributing already, okay? Number 8, collaborate with other healthcare professionals and the public. We've already talked about how you pretty much can't be a nurse without collaborating, because even if the only person you're collaborating with is your patient, you still are collaborating, okay? And provision 9 is to be responsible for nursing values, okay? Values, ethics, morality, they kind of all go together, okay? So there's several sources of ethics, which all impact one another and are intermingled, okay? So I just wanted to share this little diagram with you guys from your book, just letting you know that it's a multifaceted approach, okay? All right, an ethical problem versus a dilemma. They are different, okay? An ethical problem, it has some type of ethical dimension, meaning we're kind of conflicted with right and wrong here, but there's a clear solution, all right? Some are more complex, but there's a solution. Whereas the ethical dilemma, unfortunately, some wrong has to be done in order for the right to be done ultimately, okay? Which kind of sounds like you're going against ethics, but we'll talk more about that. All right. So an example that your book gave was end-of-life care. Is aggressive treatment, does it cause more harm than good? So for example, I was a nurse for about a year or so working in the trauma unit in Tuscaloosa, and I had a patient, she was actually medical ICU overflow, and she was elderly, probably in her 80s or 90s. She had every comorbidity you could think of. She had a tracheostomy that, we hooked a machine to breathe through it for her, and a peg tube so that we could feed her. And she was nonverbal in a comatose state. And that was not her baseline, but because of all of her sicknesses and ailments, that's where she was. And her family refused to make her DNR or to withdraw support and wanted to continue leaving her in such a state because they were collecting a check for her. And so in that moment, as I provide nursing care to this patient, knowing that, for caring for her multiple days, it's one of those internal dilemmas that you have where you think to yourself, I can give the best nursing care, turning her, bathing her, oral care, medications, communication with physicians, collaboration with therapy teams, etc. But if the end result is not going to change, is it really the best care that she could be getting? And so in my mind, in those times, it's conflict within, because I feel like even the best nursing care I can give in those situations is technically futile to the patient. Okay? So aggressive end-of-life care treatment is a great ethical dilemma because not every person, and I'll never forget my dad saying this, not every person that leaves his life has to leave with a fresh incision. Okay? So whenever he says a great sign of a great surgeon is one that knows when to and when not to operate. Okay? And so it kind of goes along with that as far as aggressive measures at the end of life. If someone has a 15% chance of making it with the surgery, or 15% chance, well, over 50%, or they're going to die basically. It's like, do we try it and they die anyway, or do we not do an operation and let them go peacefully? Kind of those kind of dilemmas. Okay. So, let me share with you about my sweet little sweet friend and patient that I'll never forget. I want to share with you the ethical dilemma. I'll just give you a couple of examples. Kind of a long story, but we're going to analyze it afterwards and go through the steps of how you analyze an ethical dilemma. So I've been a nurse for about 6 months, and I was taking care of this patient, and she had a history of alcoholism. She was no longer an alcoholic, but she had done such severe damage to her liver that she had developed what is called bleeding esophageal varices. So I'll explain. Some of you guys know what that is, some of you don't. It's okay. Haven't had that in class yet. But what happens is, and this is not testing, I'm just, giving you a story. The portal system of the liver is basically, the liver has its own blood flow, okay? And so what happens is, whenever there's portal hypertension, which is high blood pressure within the liver, the pressure goes up, okay? And so what happens is that it's a turbulent flow through the liver, and it causes the veins in the esophagus to dilate, okay, making them larger. And so sometimes they burst and they bleed and they can die that way. So what happens is these patients typically need a transplant ultimately, but in the meantime, a lot of times they get what's called a TIPS procedure. Again, you don't have to know all this, but I'll give you the background. And TIPS procedures, has anybody heard of a TIPS? Fantastic, okay. A TIPS procedure, I think you might learn all this in method. It stands for transportal, intrajugular, portocystic shunt. Okay, and that's a fancy, huge, ginormous word for a little needle stick in your neck where they go in interventional radiology and they actually put a shunt in so that we can take the pressure off of the liver and shunt it to the central system of the body. Okay? So when you have this angry, aggravated, dilated vessel in the esophagus, it now relaxes because the body is helping take some of that pressure away because we have a shunt now. Again, you don't have to know that. Alright, so this is my sweet little patient. She comes in, she's admitted, she's a frequent flyer, but I don't know that because I'm new. And so a lot of people know her. And she had an old trach site, but for some reason, I don't know if she didn't get it reversed in time, there's no trach present, but she couldn't speak, okay? Completely with it here. So people would randomly stop by to see her and they would bring like notebooks. She had like a stack of notebooks on her table. I'm like, you're popular. And it's because they knew that's how she communicated and she would just write up the stuff. So anyway, so I'm taking care of this sweet patient and she has got projectile hematemesis, which means projectile bloody vomit. Okay? Why is she vomiting? She's got bleeding esophageal varices that's sitting in her stomach. Her stomach says no thank you, so it expels it. Okay? So what's happening is she's bleeding out before my eyes. Okay? So what am I going to give that patient? Blood. Okay? Blood. If your patient's bleeding, they need blood. So I'm giving her blood unit after unit after unit after unit, but it's a Band-Aid, right? Yep. I mean, I'm filling her up, she's decreasing her tank. Filling it up, she's decreasing her tank. So finally, a GI consult comes by. And so I talk to him, and it's like end of shift. I'm about to leave a day report. And, I'm like, hey, listen, really, she needs some help. She seriously needs some help. He said, I think she'd be a candidate for a TIPS procedure. I said, I totally agree. And so he called the interventional radiologist, and he did not want to come out at like 8 at night to come and do this TIPS procedure. And he said, well, it's just a bridge to transplantation, and she's not a candidate for a transplant, so I'm not coming. So I'm like, okie dokie, well, this is not good. And so the GI physician says, oh, okay, no problem. And that's where he left it. I'm like, well, hang on a second. She needs something, and you're not providing it, right? So he told me what the doctor had said, and he agreed. Bridge to transplantation, she's not a candidate. Let me call her brother and talk to her about code stats. I'm like, wait, what? So I have to leave, but I come back the next day, and I'm upset because I know what my patient needs and that she's not getting it. And it's my job and my role as a nurse to advocate. She cannot speak verbally. I'm going to speak for her, okay? So I come back the next day. I've got my mental guns blazing. I got this, right? So I talk to the doctor when he comes through, and before he comes, I talk to the patient. And I said, I hear that Dr. So-and-so spoke with your brother last night about your code status. And she was like, she starts writing, she said, oh, he makes me sick. She's like, I don't even like my brother. I can speak for myself. Why doesn't he ask me? All these things. She's with it. Okay, that's inappropriate. So I talked to her about, her wishes and things like that. So she wanted to try this procedure. So the doctor comes through again. And I talked to him about the TIPS. And he's like, yeah, we're not going to do that. It's a bridge transplantation, yada, yada. And so I asked him, little 6 month out, of school, or registered nurse, like, you feel like you don't know what you're doing, even though you do. And so I spoke up for my patient. And I said, Dr. So-and-so, I hear you when you say she's not a candidate for transplantation. However, I feel she needs a TIPS, just like you initially did. And if it's just a bridge, who's to say how long that bridge is? Is that bridge 1 day, 1 hour, a week, a year? If this was your wife, would you not want to try? And so, put myself out there, right? That's a huge risk taking, right? I can get my butt chewed, right? It's okay though, because this looks right for her. So he still blew me off, So, I mean, he didn't like my comment, but I didn't care. And so I was very kind and respectful. So he blew me off. But, long story short, I talked to her again. And I said, listen, this is what's happening. You're slowly bleeding to death from this disease. We have this potential option. We don't know how much of a bridge it could be to transplantation. A lot of times, side note, transplants, if you have a history of substance abuse, typically you're not a candidate. Okay? So that's what they mean by her not being a candidate for a transplant. And so I asked her, so there's multiple things that we can do. What is it that you want? You know, like, do you want us to pursue taking you up with blood, you know, looking at this procedure, what is it? And so I talked to her about her options of comfort, and, you know, she was crying, and eventually she wrote the word comfort really big on her paper, and she circled it. So she basically made herself a comfort here to So I cared for her for several 12s, and she basically bled to death. We just quit replacing her blood. And so her H&H slowly trickled down until there was nothing left. So she did expire, but those were her wishes. However, the dilemma part is, you know, you feel like you're supposed to be, not that I wasn't respectful, but, you know, to speak up to a physician like that. I mean, like, I'm pretty much like putting my foot down, like, this is what she needs, and you're going to do it, kind of thing. And so it was difficult. But anyway, so I'll never forget her. She'll always have a special place in my heart. Some patients will never leave you. They'll always be with you. But anyway, it was an interesting experience. Unfortunately, I wasn't able to help her. But even if she had a tip, it could have been a day, it could have been a week, who knows, right? But ultimately, her wishes were met, and I did advocate for my patient. However, it was an ethical dilemma. Okay? All right. So, now that I've shared my story with you, let's break down the steps of processing an ethical dilemma. So, you have to first ask yourself, is this yes or no an ethical dilemma? All right. So, for my story, was it an ethical dilemma, yes or no? Yes. All right. Step 2, gather all relevant information. What information needs to be gathered?
History and physical.
History and physical, okay. What information would come from that on this patient that I told you?
Her past substance abuse.
Substance abuse. What else?
Her ability to speak.
Inability to speak. It's huge. What else? Mental capacity. Was she alert oriented?
Yes.
She was. Mm-hmm. All right. What else? Substance abuse led to? What's her ultimate problem? Cause of death. Bleeding esophageal varices. Mm-hmm. All right. So we're gathering relevant data. What other data should we gather aside from an H&P? What made this dilemma?
Her wishes.
Her wishes, okay, and the fact that initially they weren't honored, okay. What else? Later they were, but initially they weren't even sought, really. We called an estranged brother to ask about a co-status of a completely alert and oriented patient. I mean, like, it blows me away. What else? Treatment plans, yes, but the fact that the physician basically was not going with the plan that was pretty much right for the patient. Okay. All right. Clarifying values. So you have to reflect inwardly. I went home that night and was thinking upon what was going on with the patient. What could I say that would be respectful? What that was advocating? You know, I'm thinking through the process. Okay. The values of her values, my values. Of course, I'm not going to impose mine on her. However, they affect me and my capacity to speak up for her. Okay. All right. What about step 4? Verbalize the problem. What was the problem?
She needed a procedure. They were refusing to go.
She needed a procedure they were refusing to do and give her. Okay? Alright, so step 5, what are my possible courses of action? There's multiple.
Procedure.
Okay, course of action was, she said procedure, but I have no control. I can't actually physically do the procedure. So yes, the procedure.
Carrying out her wishes.
Carrying out her wishes, okay. So in the end, that's what we did. But initially the problem was, and the dilemma was that her wishes weren't sought. So a possible course of action would be to take it as the physician said, oh, we're not doing that, yes sir, I'm bringing I know nothing, okay, no problem, and then just let it go, okay? Is that being an advocate for my patient?
No.
No. Okay, another option is what I actually did, what did I do?
you sat down and you sought her wishes and what she wanted to do.
Right, I sat down, sought her wishes, informed her of every step of the way, what it was we were doing, and why, okay? And then let her have a say. I built that rapport with her, the nurse-client relationship, so that she could have a say in her treatment plan. And if she said she wanted that tips, I was going to fight tooth and nail until she got it. And she decided ultimately she didn't want that, so I let it go because I wanted to buy back her wishes. Very good. All right, step 6, negotiated plan. Well, initially, what was my plan?
Get in the procedure.
Get her the procedure. Okay? I want to do what's right for my patient. And, nobody is God and can decide how long that bridge is. Okay? All right, negotiated plan. Ultimately, what was the plan in the end?
Comfort.
Comfort. Very, very good. All right. Step 7, evaluate the plan over time. This is reflection. We're doing this right now. This is years ago. Years ago. We'll never forget her. She's precious in every way. But we're evaluating the plan. Was it effective? What do you think?
If she would die comfortably, yes.
She died comfortably, so it was effective. In the end, we can't save them all, but we will definitely try if it's their wishes. Okay? Now, if it's not their wishes, we shouldn't do that, right? So there's a box in your book that basically just breaks down all these steps, but I wanted you guys to have an opportunity to apply them for a real life example. So does that help you guys for the steps? Okay. All right. Ethical principles. So these are ones that HESI loves to test. And my poor students, when they hit me a fourth semester, it's like they don't even know what these are anymore, and then it's on their exam. They're like, please help us. So you're going to try to commit these to memory, okay? Because they will come up in future exams as well. All right? So, your book says that ethical principles are similar, that's awesome, similar to a camera lens, okay? So they can have various magnifications or filters, all right, depending upon how they're viewed. So depending upon how you look at a certain situation and which principle that you're utilizing, okay? So here are the principles that you need to know, and we'll go over each of them, okay? So we have autonomy, which can also be commonly referred to as respect for persons, beneficence, non-maleficence, justice, fidelity, and veracity, okay? So first is autonomy, which is, of course, respect for persons. So what does autonomy mean just in your own terms?
Treating someone the way you want to be treated.
Treating someone the way you want to be treated, okay. So what if I said someone was acting autonomously?
On their own.
On their own, independent, very good, yes, okay. And so, like you said, doing what is right by the patient, they're acting on their own, and so we must commit to include clients in all healthcare, okay. We have respect for them as a person, and they have a right to their healthcare and to have a part in it, okay. So, we have to act independently to advocate for them and help meet their needs and include them in this plan, all right? So, they have the right to self-determine a course of action without coercion. What's coercion?
Being forced.
Yeah, being forced, somehow being influenced. Like, I know you really don't want this surgery because you're 31 and you have breast cancer, but you really should consider it. Because the money's everyone, right? If they want herbal supplements, they want herbal supplements. We should do that, okay? Remember that example for a previous class. So they have the right to determine what it is that they want, okay? They must provide all information for clients to make their own decisions. Consider health literacy. What does that mean? Why are we considering literacy?
What they're capable of understanding.
Very good. What they're capable of understanding. So if you're trying to provide all information, but you provide it in a way that they can't understand, such as using jargon, you're going to have a TIPS procedure because you've got bleeding esophageal varices, and radiology is going to come get you to do that. What? Okay, that's like, I don't even know what that is. Okay, so a way that I could explain that to the patient is because your liver is sick, it's causing problems with blood flow, which are causing you to have these vessels in your esophagus to enlarge. And so they're going to do a special procedure that's just one little needle stick. Okay, and through that one little needle stick, they're going to help us move that blood that is causing increased pressure from your liver to the rest of your body as well. Okay, so literacy. You're going to explain it in a way that they can understand and give all information. Because it would also not be appropriate to say, hey, Found his consent, we're doing a tips and radiology in 30 minutes. Dr. So-and-so is going to do the procedure. We didn't explain all the information, okay? Alright. Lastly, we say this more than you probably want to hear, but it's the honest truth. You're the client's advocate, okay? So a good example of this is as we were saying, signing informed consent. And informed consent means they have to be informed about what it is that they're signing and agreeing to. Okay? Beneficence is the duty to do good. Okay? Goodness, kindness, and charity. I think about the golden rule with this one. It's the centerpiece for all caring, and it has the best interest of the client. Is more important than your own self-interest. Okay? So it is doing good. Then you have non-maleficence. A lot of times students get these two mixed up, but I'll give you some tips to help you keep them straight. So, it is a duty to do no harm. Well, you think if you're doing no harm, technically you're doing good, right? In a sense. So that's kind of how students get those mixed up. But it's a duty to prevent or remove harm or risk for harm. Okay? It's more binding than beneficence. I kind of also think about negligence as an example for non-maleficence. What's negligence? Do you want to talk about this with safety at all?
You're allowing the potential for harm.
You're allowing the potential for harm, okay? Also, if I'm negligent to my patient, what does that mean?
You're not caring for them.
I've abandoned them. I'm not caring for them, okay? Well, if I'm negligent to them, then I have no clue if they're even at risk for harm or they're being harmed because I completely abandoned them, all right? So, it's the balance of the risk versus the benefits. We're striving to do the least harm possible. So an example that comes to my mind is a very simple example, but it's like starting an IV. Alright? So we have a duty to do no harm. However, when you stick your patient, you're technically harming them a little bit, right? But putting the IV in is something that they need, and so the benefit outweighs the risk. Does that make sense? One little needle stick. It's not the end of the world. We technically have a duty to do no harm, but if they get an IV, then fine. They can endure a little bit of pain if the risk, the benefits outweigh the risk. Alright. Justice. It seeks fairness for everyone equally. Okay? More specifically, distributive justice, which is where we have the distribution of scarce resources. Okay, so in a scarce resource example might be like in a disaster. Okay, you try to use the most supplies for those that would do the most good for. Okay? So it would be equally dispersed according to need, effort, and merit. Also, we do not want to discriminate based on socioeconomic status. So we're going to provide care for everyone equally. It doesn't matter if we have one single thing in common with the patient, or if we completely disagree with everything about them and their lifestyle, we are still going to treat everyone the same. Okay? And that is very difficult. It's very much been done. Alright? Questions so far? Y'all hanging in there? Okay. Fidelity. The duty to be faithful and loyal. Alright? It includes implicit and explicit promises. Okay? So if you make a promise, you gotta follow through. And this seems easier than it really is, but a common thing that we technically don't abide by this ethical principle is I'll be back in just a sec. Okay, well, did you really come back in a sec?
No.
No. So some of those things that, if you make a promise, I'll be back in 30 minutes with your IV morphine, it'll be time at that point to administer it to you. And you're back in 50 minutes. Did you keep your promise?
No.
No. So be very, very careful about what promises you make, and whatever you make, follow through with, okay? Unwillingness to abandon clients regardless of circumstances, even when personal beliefs differ. So let's say that you have someone that believes differently than you do, another religion, or they had other spiritual beliefs. A common one, very common, is let's say that you do not believe in abortion, but the patient has had abortions in the past, it's in their medical history. Are you going to change the care that you give those patients? No. Internally, you might have a struggle with that, if that's what you believe. However, they should never know it. Okay? So that is something that you have to make sure that you follow through with your promises. Another thing is, caring for patients, how we talked about those that believe differently, also those that lead different lifestyles. So, for example, a prisoner, someone who's done something wrong, and they have been convicted of a crime. So I took care of a patient It's another long story, but students love it, so everyone. So I took care of a patient in the unit. When I came here, I previously worked in the trauma unit, so I started in this trauma unit. It wasn't a big deal of a transition, thankfully, because I'd already worked in one before. So it's probably like, I don't know, week 4 of orientation for me. And orientation is basically just me getting used to the system and the physicians and how we do things here versus at home. So I have this patient I get a report from, and the night shift nurse tells me he's a prisoner, and that she thought it'd be more secure to take off his handcuffs and put wrist restraints on him. So that's how my report began. I thought this is going to be great. So my first thing to do after I go in there is get those swapped back, because I'm sorry, wrist restraints with ties are not as secure as cuffs. So I don't remember what brought it. Like, I don't remember what he did. It doesn't matter. What he did is a crime, because I'm gonna take care of him either way, right? Just like he's my brother, even though I don't agree with his lifestyle. He is still a person and he still has needs. So he came in because he had been banging his head on the cell wall. Okay, he had like a big old gash in his head. And also he had been like bearing down, like so much. I don't know why, if he's just angry or what he's doing, but he had caused, from doing that so much, he had caused what's called subcutaneous emphysema. And that is basically air under in the fatty tissue. So if you felt it, it's like Rice Krispies under the skin. Okay? So we're like, this is very odd. I've never seen that. Typically sub-Q air comes from chest tube. There's a little leak at the site and the air leaks through, or they had a pneumothorax or a stab wound or something. I'm like, this is weird. So he's in there, and we have him in a semi-private room. Mistake number 1. Let me put it in there. But, so at first I go in there and I'm doing an assessment. He's kind of acting like a little punk, he's like not talking to me, just whatever. I'm like, oh no, I'm thinking to myself, we're gonna become friends, okay? You're gonna cooperate, I didn't say that, but I'm like, okay. So I get his cuff swapped back. Of course, he has a cuff that stays in his room. So he gets kind of bored, and the ENT doctor, your nose throat, came to see him to see if there's something wrong with his throat or something. Like, why are we got this sub-Q air all around his neck? This is very strange. Scoped him, looked fine. Looks like a mystery guy. So then, I guess he tries to spice it up on us. I don't know. He starts faking psych issues. Okay, like legit faking. You can tell. Okay. So like a doctor would walk by his room and he'd be like, "Jesus!" And I'm like, okay. Like no. And then nobody else walked by, he's quiet. Somebody else walked by, they trying to kill me! Like all this stuff, like really dude. So then, all of a sudden, I hear this little old lady, she's in a semi-private room, she pipes up and she's like, "Excuse me, is he gonna be okay over there?" I'm like, oh snap. She's a little 8-year-old with a bowel repair, like, come on now. So I'm like, we're gonna end up having to move him eventually, just do that. So, it turns out they decided they wanted to do a swallow study on him under fluoroscopy in speech therapy department. That means we gotta mobilize some way, right? Okay. Alright, so yay me! This is awesome. Everybody's like, she'll quit after today, maybe we'll keep her. So anyway, so he keeps acting a fool. We end up moving to another room, praise the Lord, because little Meemaw couldn't handle anymore. She's nervous right over there. I forgot I didn't, so she got a lot done that day. So anyway, so we moved in this room. He's still acting a fool. Of course they do a site consult. That's what he wants, right? He wants drugs. Okay? He wants all those meds to put him out, so we'll stop doing that, right? So while we're trying to get everything ready, we're doing put the orders in, we're gonna go to fluoro, all that stuff, he starts acting even crazier. Okay, so I started there with one cop. My unit director's in there, majestic in every way. She retired in the summer, I miss her every day. We have a great one as well now, but she's been there for 35 years, and oh my gosh, she's amazing. So we're in there, she's in there, the charge nurse is in there, the ENT is in there, she's been there for 15 years. And so we're trying to hold him down at this point, because now he's gone from faking these religious ideations to now he's seizing. Okay? Not even close to actual seizures, but he's seizing. Or he's acting like he's convulsing. He's convulsing. Alright, so they're like, get some Giadon, some Haldol, all this stuff. So I'm in there doing like a cocktail, in the bedroom. Thank the Lord I know how to draw and stuff, because I would be freaking out if I was doing. And so I get in this room, cool as a cucumber, Susan's at the head, different people that got arms and legs out, and I have 6 cops in my room. Yes, 6 cops. Okay, thank the Lord Meemaw's not next door anymore. So I hook the Haldol and Giadon, which is like antipsychotic, like sedative kind of thing, for psych patients, and I hook it to his IV, and he sees me, and he bites the IV out of his arm. Really? Really, bro? That's the only one I have. So then what do? Thank goodness those two medications, because you know there's like drugs, there's like people who do different things. They're IM compatible. So I get a needle, and now a convulsing crazy man with 6 cops and 5 different nurses holding him down on the bed. I gotta put a needle in his leg. So my unit director, she's fearless. She's holding his leg, so I did the vastus lateralis, right there. Y'all learn about that next semester. But anyway, so then, of course, we pop him with the drugs, and he's like, ooh, I feel drunk. Like, he loved it. Really? Whatever. You're quiet. So then, I'm like, okay, we gotta take him downstairs. And this is gonna be so special. So, we take him down, we roll him in his bed, so we do with ICU patients. He's not, super sick, but he's got this situation, so that's why he's with us. Around his airway, right? So we take him down to fluoroscopy, and we have to get him out of his bed and put him in this little chair to sit in front of this thing where they can watch him swallow all this mess to make sure his swallowing's okay. So you have to wear lead if you're in this under fluoro, okay? So I'm standing behind the shield and everything, but the cops want to stay with him. They decided to all stay with him. So I start passing out lead. You took the lead vest with thyroid shield from the wall. I start passing it out. Y'all, it's awesome. I got these burly cops like this. It was like glitter sparkles and rainbows and like unicorns. All the patterns were like super fruity, and so they were just like sitting there with like glitter. I loved it. It was the best. I wish I could take a picture, But anyway, so they're sitting there like, through the whole thing. Everything is fine, and so we've done everything we can for this man. Just gonna send him back to jail. So they're like, okay, forget it. So we take him back to the room. He's still kind of acting crazy, but we've tried everything. This is not going to kill him. Sub-Q air will absorb itself. His swallowing's fine. So they decided to discharge the man. All right. All of a sudden, we get his wheelchair, get all his paperwork, everything together, have all his papers in his little green folder, and the cop's like, I'm going to throw that away, right? I'm like, yeah, but you know how to do it anyway, right? It's like, sure. So I give him a little green folder. I try to put him in the wheelchair. Then all of a sudden, his legs are miraculously broken. He can't move. So he won't get in the wheelchair. We're like, seriously, dude? And also, by the way, at one point he had asked for a cheeseburger, and Susan and all her little sweetheart went and bought him one, and it wasn't good enough. So there's that. But see, I'm still treating him like I would treat anybody. He is making my life very difficult, but I'm not going to mistreat him, right? I'm going to make sure that I do justice and fidelity, okay? So, ultimately, we finally get this man in this wheelchair. So, he has no belongings, okay? So he has a hospital gown on. So the cops tell us to meet him at the Circle Drive out front, where the fountain is. I don't know if you guys are familiar with Huntsville Hospital. It's like the worst place they could have picked him up. So we all go down there, me and Anthony and Susan. Susan's the unit director, Anthony's in charge, me and Cassie, she's morning me. So we all go down there. I'm like, this is great. So great. Because his legs are broken now, they're broken trying to get in the cop car, right? So we wheel him down there, and the second we hit outside, there's like peepholes and peepholes, getting discharged, and everybody getting their little cars and stuff, and he's over here like, they're trying to kill me! Mama! Save me! Like all this stuff, we're like, sir, we need you to stop screaming. Makes him louder, we're like, great. So they pull around the cop car, and all of a sudden, the cops are trying to get him in, and he starfishes. So you can't get him in. I'm serious, this is a true story. And so, me and Susan look at each other like, this thing. So I look behind me, and there's this lady who's got her phone, and she's like, not today, Sam. I turned around, and I said, ma'am, please turn off your phone. You do not have authorization to put my backside in any of this scenario on the internet. That's inappropriate. Oh, I wasn't. Shut it down, please. Okay? She was like, oh. All right. So this is during the times where like hot brutality is like a bad deal, and so they don't want to, like make a scene because it's in front of everybody out there. So they called backup. The state trooper, legit, like squeals in. Okay, he's done with this. He walks up, he tases him, they throw him in there. And he was on his merry way. However, I forgot the best part of the story. When he starfished, the gowns were butt. That's when the lady is like. So anyway, so that is my little story about you never know what you're going to see, what you're going to do as a nurse, but you can't change how you provide your care. Okay? So even though he was a punk and he tried to make my life horrible that day, I went back up to the unit and there's like 5 nurses like looking out the window. And they were like, if she doesn't leave after today, I guess we get to keep her. So I'm still there. So it's all good, but so when you take care of drug dealers, you take care of prisoners and rapists and murderers and all these other people, it's the truth. It's the truth. And as crazy as it is, and as good of a story as that gave me, I still have to, treat him the same. Okay? So you can think back to that chaos whenever you see a patient that has made choices that you disagree with. Okay? And just realize all that we went through that day, all of his antics, and how I still would never raise my voice, was never rude to him, etc. Okay? Alright. Feel like I got a story?
Yeah.
Okay. Alright. Veracity. It's the obligation to tell the truth. Yes, tell the truth. Never lie, okay? And for future, by the way, with that story, if I ever have to discharge another patient in gown, I'm gonna put one on the back too. Because, bless it was, and it was in front of God and everybody out there in front of the fountain, and it was horrible. Alright, so, never deceive anyone, always tell the truth. That one's an easy one, okay? You can just remember the name. Alright. Ethical theories. We'll get through this and I'll give you guys a break. So, these are from your book. Deontology, which is a moral duty, and it is the right thing to do. Okay? That's kind of the moral philosophy. Do it because it's right. Alright. Utilitarian is the greatest good for the greatest number. Okay? And your book goes into more detail about this. You just kind of know the basics, okay? Alright, ethics of character, virtues. Alright? Based on life experience and willingness to reflect on our own actions. Be virtuous. Lastly here is ethics of relationship and caring. Okay? So nature and obligation inherent in human relationships. Okay? Alright. Ethical issues in nursing. So protecting clients' rights and human dignity. That's a hard thing to do. Not necessarily because you don't want to, but because you're faced with all of these different things that make it more difficult for you. Okay? Not respecting informed consent treatment. That one's huge because technically by the book, physicians are supposed to be the ones that obtain consent. Have you ever signed a consent before? Was a nurse with you when you signed it, or was a doctor with you? The nurse. Okay? So technically the physicians are supposed to obtain it themselves. But the way that we kind of do it at the hospital is if the physician's like, hey, I need you to get consent for arterial line placement. I'm like, okay, well, did you explain the risks and benefits to the patient and family? And so I don't mind getting a paper signed, but you're going to do the explanation. I can do the explanation because I know it, but that's not my role. Okay? So that's one of those things where you want to do what you're told, yes, doctor, because they tell you. But technically, the right thing to do is they have to inform.
So the nurse get the consent and the doctor inform the patient.
That's how it really is in the real world. Okay. Book world, perfect world, the doctor explains and the doctor does the paperwork. But real world, we typically get the paperwork and sign as a witness. However, it is a physician's role. If someone's going to operate on someone or do a procedure, it's only right for the person doing so, whatever the procedure is or surgery, to explain what it is they're going to do and what the risks and benefits are. So it's not up to the nurse. Also, until you become experienced, can you imagine being a new grad and all of a sudden they say, hey, we're going to do tips, go ahead and get me consent, and you're like, there was that one time we talked about tips in class, what was that? It's not fair to put that on the nurse. That's not their role, okay? So as you get experience, you can kind of learn those things, but yes, the physician's ultimately responsible. So you can see how that's kind of an ethical issue, doing what you're told versus what you know is right. All right, providing care with risk to the health of the nurse. Give an example of this. Many things that we do.
Patient has HIV.
Patient has HIV? Do you know what kind of precautions you use for patients with HIV? Standard precautions. Thank you, senior nursing student about to graduate, Mr. Aaron. All right. Yes, standard precautions. Let me tell you what those are. So you'll learn about these in fundamentals. The standard precautions are basically what you do for every patient every time. You treat an HIV patient the exact same as someone that has no infectious disease. Okay? So basically you just do gloves and hand hygiene. You're not going in there in full combat gear the mask, gloves, hat, gown, all that stuff? No. So, be very careful. Alright, what else? What else do we do that puts us at risk?
Obese patients.
Obese patients, how does that put us at risk?
Well, if they fall or like you have to pull them over on the bed, you get back injuries.
Yes. Very much. Back injuries. Lots of nurses have had to have back surgery. Someone else said something.
Combative patients.
What? Oh, combative patients. Yes. Are you really a nurse if you're not going to beat on, poop on, kids, fat at? Then all of those. They kicked in the head by a psych patient. Really? He's a full strength. But yes. So there's many things. Also, after you give an injection or with a needle, when you're trying to walk off your needle or you can stick yourself with a contaminated needle. You take care of patients on precautions for superbugs. Okay, bugs that can cause serious infections that are very difficult to treat. Okay? Alright. Using or not using chemical or physical restraints is an ethical issue. Why is the use of restraints for patients an ethical issue?
It can cause more injury.
Okay. Okay, if they don't get consent, it's bad. Okay, so technically, the patient, most times when they get tied down, they don't really want to be tied down, but they get tied down anyway. So a lot of times we don't ask the patients if it's okay, because most times they're in a state where they can't really deem if it's appropriate or not, or we wouldn't tie them down. Okay? Why else would it be ethical? An ethical dilemma, or an ethical issue rather.
You're kind of harming them.
You're kind of harming them. Okay, in a sense, you're not really physically causing them harm, but they're, like you said, they might struggle against them. Okay? So one key thing you probably talked about with safety last week is keep this in mind for all tests. Our tests, HESI, NCLEX, and LIFE. Okay? And that is least invasive to most invasive. Okay? If your patient, you feel like they need to be tied down, you're probably going to try something else before you tie them down. Okay? So it's kind of like you have a headache at home, you're probably going to take a Tylenol before you call the doctor for 2 milligrams of IV morphine. Okay? It's kind of like another random example I'll give you is if you see a fly, you might swat it with a quick little fly swatter, but you're not going to throw an anvil at it. Okay? You're going to do least invasive to most, if it dies with a fly swatter, leave the anvil alone. Okay? Same thing with physical restraints. Try something that is least invasive, like orienting them to what's going on. Get a family member that knows them. Yes, family sitter. A sitter, yes. A sitter that knows them. And then if you still end up having to tie them down, then a lot of times the family will be in agreement with you or see why it is you're tying them down. Rather than showing up and being like, why did you tie them down? Okay. So it is hard. We try not to restrain people, but also there are times where they pull out devices that are trying to help them because there's delirious. Especially in my unit because of ICU delirium. And anytime a patient's on a mechanical ventilator, we tie them down. And that's hard, because sometimes they're a little more awake, but we try to sedate them so they're not like fighting. But I always explain to them that if you were to fall asleep and wake up, it's not normal to have all this stuff on your face and a tube down your throat, and so you might, out of like a reaction, gutturally try to pull that out. So that's why we tie them down. Okay? And now I don't mean like ridiculous, okay? You can give a little bit of slack. But you'll be surprised. I've had a patient in 4-point restraints and a body holder that tying them to the bed excavate themselves with their toes. Okay?
Seriously?
True story. Yes. And another key thing is, not testing for this class, but just real world. You know those ambu bags that you bag people with? Mm-hmm. The bag valve mask is the formal term. Don't ever throw away the mask. Okay? Because when they're intubated, you don't have a place to put the mask. You hook it to the tube. People just chunk the mask. So now they're excavating themselves with their toes. What are you going to do? Ask them to wrap their lips around the ambu? No, you need a mask. Okay? Because what happened to me, new grad, just got report, patient excavated himself with his toes, and I reached for the ambu, there's no mask. So, learn from my experiences. Although that wasn't my fault, that was my shit's fault. But it's okay. Alright. Only because I had just come on the shit. I've been there more than 5 minutes, it was my fault. Alright, understaffing. Why is that an ethical issue? Burnout. Yes. Alright. Do we have mandated staffing ratios in our states? No. No, we do not. So, part of what makes understaffing an ethical issue is because typically we know a certain ratio, nurse to patient ratio, that's safe. But if you're short, are you going to neglect the patient and just leave him hanging? Sorry, sir. We don't have enough nurses today. You're gonna pick up that patient and do what's right. But then that's what's wrong for your parents, right? It's too much. So that's a very difficult thing. We deal with it all the time. That's why we need more nurses. We have a shortage. That's where you guys come in, okay? And get you graduated. All right, prolonging the living and dying process with inappropriate measures. We've already talked about that one. Policies that can threaten the quality of care, okay? So that is definitely something that can happen. Certain policies can be written and by people who don't actually care for patients at the bedside. We are what's called frontline providers, okay? We are face-to-face direct care with patients and their families. And sometimes, not always, but sometimes people write procedures and policies, ways that we can do things, and they don't actually have that experience. And so it makes it difficult because when we actuate those policies, sometimes it's really not what's best for the patient. And so we would utilize the just culture there to speak up about that. So hopefully we can make a policy change to improve quality of care. All right. Lastly, is working with unethical or impaired colleagues. This really happens, guys, especially in our day and age. Yes.
I was just going to ask them for the policies that could threaten the quality of care. In your story, how they said that they don't consider substance users candidates for the tips, would that be considered a policy that threatens the quality of care?
Oh, that's a great question. If there was a formal policy that said substance abusers could not have a tip, then yes. Technically, that was just opinion of physicians. There wasn't a formal policy. As far as organ donation, there is a formal criteria that they look through to see who is and is not a candidate, and substance abuse is one of the things that rules them out to being a candidate. So that would, I guess, technically be a policy or criteria, but it's not necessarily in a hospital. So that's a good question, though. Any other questions? Yes.
Okay, if they do write a policy that's bad, that's what's gonna happen. But if you get in a situation where you're gonna use that policy and you're like, this isn't gonna work, you just abandon that and do the right thing.
Yes. And that's the hard thing, though. So that's when technically you'd be in error and violation of the policy, but then you would be doing what was ethically and morally right for your patient. And that's where you couldn't just do that and just sweep it under the rug. You'd have to speak up and say, hey, I know our policy says this is what happened. I decided to do this instead. I realize it's a violation of the policy, but I wondered if you would take a look at this moving forward, because if it's an ethical dilemma for me, it's going to be an ethical dilemma for other nurses. So, or ethical issue. So, very good question. Very good question. Now, I'm not telling you to go against policies, but only if it's legitimately going to cause your patient harm, or there's a typo or something. So, very good. Working with unethical and impaired colleagues. This is huge. Huge, because it's more common now than ever. If you see someone that you feel is impaired, nursing school, working at the hospital, clinical, after you graduated, etc. If you feel like they are impaired, you have a duty to report it. You can't say, well, they had a rough night and move on with your life, okay? It is not okay. All right, or you smell alcohol, or you smell some type of drug or something. You got to report that. It is the right thing to do. Why is it a priority? You're not trying to just be in somebody's business, okay? Why is that a serious concern and priority for us as nurses?
Well, that puts the patient at risk.
The patient will be at risk if that person helps care for them, okay? And even if they don't have direct patient contact, if they're impaired in any way, they might be a danger to themselves or others, okay? We don't need them falling out, okay? So that's a really big deal. All right. So these are interrelated concepts. And, okay, so if you guys will take let's say a 15-minute break, and then we'll come back and do an activity, okay? All right.
15. Okay, the longest we're going.
No, right?
Are you?
I just saw it now.
Yeah.
Actually.